My name is Sam Gudoi, and I'm the Chief of Party for USAID's Malaria Action Program for districts. I'd like to thank you for the opportunity for me to share with you some highlights of the malaria work that MAPD has supported in Uganda. And this support has been made possible by the generous support of the American people through the President's Malaria Initiative, USAID, that provided $41.5 million US, enabling USAID to enter into a partnership with Malaria Consortium as the prime implementer of this project, in close collaboration with its consortium partners, Japaigo, Banyan Global, Communication for Development Foundation Uganda, Deloitte Uganda, Infectious Diseases Institute, and the Infectious Diseases Research Collaboration. And indeed, through a strong partnership with the government of Uganda, through the Ministry of Health, mainly the National Malaria Control Division, but as well the Child Health Division, as well as the Division for Health Information, and then 53 districts and health facilities and communities located in the West Nile region, the Central region, as well as the Western region of Uganda. And I'm going to be sharing with you an overview of the project, as well as the project mainly focusing on the project design, as well as the key approaches, and then I'll also be sharing with you some aspects of the trends in regard to the targets that we set out to achieve. And then we'll be making some recommendations which are actually based on our learning through implementation and interaction over the course of the project period. And for the details of all these and about the project, we'll be referring you to the various project reports, various success stories that are available on the Malaria Consortium website, as well as on the USAID website. We have worked in support of the Uganda Malaria Reduction Strategic Plan 2014-2020, as well as the Uganda Malaria Reduction and Elimination Strategic Plan 2021-2026. And our goal has been to contribute towards the reduction of malaria morbidity as well as death related to malaria in Uganda, mainly focusing on pregnant women as well as children below the age of 5 years, a total of an estimated 14 million people, which is about 37% of Uganda's total population. In terms of results, a synopsis, we have supported prevention, case management, and capacity building efforts at all levels, at the national level. 53 districts, close to 1,600 facilities and communities, and we have supported all interventions, including behavior change communication, aspects of gender and youth mainstreaming, the monitoring and evaluation data aspects, and then we have fostered learning as part of our program implementation at all levels. And over the period of 5 years, since 2016 to 2021, we can share with you how we have progressed in regard to our targets using the latest data, which is October 2019 to September 2020. We'll be showing you how the interventions have performed across the maternal-child prevention initiatives, across the access to early lines, as well as testing, and then as well as treatment, and then regarding admissions, and then ultimately how it has been in regard to malaria-related death. You will see from this graph that IPT3, which is the prevention of malaria among pregnant women attending ANC, has actually improved from a low of close to 2% to currently at 58% across the MAPD districts. And if you look at that in comparison to the national and then the non-MAPD districts, you'll see that performance across MAPD districts was quite enhanced. The same applies to IPTP4 as well as for the access to the long-lasting insecticidal nets, and then testing, which is close to 100, and then most importantly regarding treatment, where the health workers have complied with the testing requirement before you treat malaria, and then admissions due to malaria, which have also reduced, and then mortality, which has reduced greatly by about 50% from the time the project actually started. And then this is more data regarding to malaria-related death, and you'll see that in the current year, which is PY5, for 3 quarters, the number is actually less than 1 quarter in year 1. And what's important is that this reduction in malaria-related death has actually been consistent. You'll see that from year 1 through year 2, year 3, and year 4. And finally, when the project is closing, mortality has been greatly reduced. And when you compare this to the national targets, you'll find that the malaria-related death in MAPD districts is actually 0.25 deaths per 100 admissions compared to the national target of 0.4. So this is well achieved. And the lesson we actually learn from here is that it's possible with the required resources, with the required commitments, with the participation of critical stakeholders, with the Ministry of Health leading, with the districts leading, and communities being reached and participating. It's actually possible to reduce malaria death in Uganda. And then when you look at cases, you'll see again that there's been progress in this aspect. From the first year, you'll see that currently cases are reduced, although you'll see that in year 3 there was actually an epidemic and cases increased. However, this is also attributable to the fact that MAPD, working with its partners, improved access to malaria services as well as quality of the malaria services, so communities, beneficiaries had confidence in the services and they are able to access them, and therefore the numbers increased. So again, while the cases increased at a point, but what's more important is actually the quality of services that are exemplified by the reduction in malaria-related death. Here we want to just share a bit of the details regarding the prevention of malaria in pregnancy, demonstrating that in year 1 you were barely at 2%, and at the time we are closing, IPTP3 is actually at 59%. And then you'll see that in year 4, when we started recording IPTP4, it was at 51, and right now we've already moved 17 points and at 68%. And the key strategy really has been about collaboration with the different stakeholders. We have ensured that there are correct linkages across board. We have ensured that the guidelines are updated and disseminated, and that health workers are fully equipped with the required skills to deliver these services as required. And the quality of services has improved. And then there is, of course, also the aspect of community mobilization, where mothers have been mobilized to attend the ANC, and therefore they are able to access these services when they come for the ANC services. And with increased ANC uptake, they are able to get the prevention services. When we look at the aspect of access to nets, you'll find that again, beneficiaries accessed LLINs, And this is because, again, there was technical assistance at all levels, working through the relevant structures, like the integrated vector management thematic working group at the national level, like the district technical resource persons, as well as the facility ANC providers, ensuring that there is appropriate quantification of the needs, and that there are no stockouts of nets at those levels, and that districts and facilities own the storage of these commodities, as well as the transportation to the last mile, and then the relevant SBC approaches, ensuring that people appreciate the importance of early lines and actually appreciate the risk they are at from malaria, and then being able to sleep under the nets every night. We have supported the delivery of early lines mainly to the pregnant women through the antenatal clinics, to children through the immunization clinics, as well as to the general population through the universal coverage campaigns. We have also worked with the districts, ensuring that districts own the early line distribution system, where they are responsible for storage as well as transportation to the last mile. But we have also provided additional nets through the schools and through outreaches to hard-to-reach communities, and most importantly, ensured that people that have nets in households actually use them to achieve malaria prevention. As you will see from the data we have from the community surveys, 3 community surveys, including the ICCM survey, the SBC dipstick survey, as well as the community household survey. There was a consistent increase among children under 5 years that slept under a net prior to the conduct of the study, as well as a consistent increase among pregnant women. The national target is 85% for both children and the pregnant women, and you'll see that for children this was nearly achieved, while for the pregnant women it was also there about to be achieved. And then when we look at compliance with the national policies and guidelines in regard to malaria diagnosis and malaria treatment, you'll see that by about the 2nd year of the project, coming into the 3rd year, we had already surpassed the national target, which was 95%, and almost all malaria suspected cases to the level of 98% were consistently tested before they were diagnosed with malaria and before they received malaria treatment. And this again is really about building the health worker skills. It's about providing the requisite guidelines for diagnosis and treatment. It's about quantifying the necessary commodities, both malaria rapid diagnostic tests as well as the SCTs that are needed for treatment. And again, we ensured that there were quality improvement initiatives that were instituted across all levels of care, and consistent support, supervision and mentorship across board. And you'll see that all these are actually related to the treatment practices by the health workers at the facility level and even at the community level. You will see that compared to the national target, where it's expected that at least 5% of persons testing negative for malaria receive antimalarials, within the MAPD districts, you'll see that it's actually between 2 and 3%. Again, in this area, the target performance has been surpassed, and the strategies remain the same as linked to the diagnostic aspects. And then regarding the capacity building aspects, you'll look at the model as we are highlighting it here, which focuses on policy and strategy and guidelines, and then the management aspects of the program, as well as how the services are delivered. And then you'll note that through improved leaderships at the national level as well as at the district level, and then responsiveness at the district especially, and facility and community level, and then the people skills that we have developed will be able to lead us to performance of functions, especially about solving problems and appropriate decision making, and then improved capacities across board, and as well as fostering the culture of continuous learning and integration and improvement of quality. This has resulted into our enhanced performance in terms of reduction of malaria-related death as well as malaria cases. Now, in terms of real capacity building strategies, really these cut across again at the national, district, facility and community level, and they focused on technical assistance in terms of policies and guidelines. They focused on training key staff, core staff that continue to support service delivery at the different levels, involvement of everybody, especially the Ministry of Health, in terms of trainings, in terms of reviews, and in terms of guideline development, and support the structural setups like the working groups in the different intervention areas like monitoring and evaluation, malaria in private pregnancy as well as private sector, and then aspects of commodity security in terms of quantification, in terms of tracking, in terms of redistribution, and then also we're able to provide resident counterpart staff to the Ministry of Health to support critical aspects that were key to the program, like the malaria in pregnancy specialists and then the entomology specialists. And we have emphasized collaboration, learning and adaptation, where lessons are plowed back into programming. We have also supported operational research, mainly tailored to ensuring that we have up-to-date data regarding the efficacy and effectiveness of the malaria treatment medicines. And we have also supported through the in-kind grants some aspects that are critical to service delivery, such as building modifications, such as aspects to do with data management, and then aspects to do with the diagnostics, mainly the microscopes. And then that actually enables us to transition the program as we close to ensure sustainability of these results, ensuring sustainability of the approaches, and ensuring the program is fully embedded within the operations of the districts, the operations of the Ministry of Health, as well as the facilities, and most importantly, even in communities and household levels. And this is premised in the design of the project because we've implemented through the existing national structures, through the district structures, and that the people that have been the face of the project has actually been the Ministry of Health as well as the district and facility team. So the skills are there, the people are there, the program is transitioning. And then we have engaged with the political and administrative and all technical persons at the different levels. We have actually developed the capacity building plan, which is participatory, and we have used the data to prioritize and focus resources where there is greatest need. And then we have also emphasized the integration into the existing programs, especially in the district annual plans as well as district budgets and facility as well. And then we have had a stronger advocacy for many of the interventions we have supported, and then we have actually had a strong social behavior change initiative which has empowered people at community level as key influencers, and with this we are confident that they will be able to take forward the malaria drive in those communities. And this therefore enables us to make some recommendations which are actually based on our learnings from the program implementation. First, it's about the program in terms of how it should be designed, how it should be implemented. We've learned that it's critical that there is enhanced public-private participation, partnerships, initiatives, which are within the governance and the coordination aspects, and that these should cut through at all levels, mainly the national as well as the district level. And then we should actually strengthen data use so that we direct our resources based on evidence and with appropriate prioritization. And we should be able to continue advocacy for improved ANC attendance and ensuring that every pregnant woman who attends ANC has an opportunity to receive malaria prevention. Commodities are critical for you to be able to improve prevention services, and then for you to be able to improve diagnosis and treatment services. And in these commodities, specifically about LLIN, would like to recommend that there is a clear national plan for LLIN supply, as well as a coordinated supply that enables seamless availability of these commodities at the facilities to be accessed by the beneficiaries. And then in terms of case management, we recommend that we strengthen parasite-based diagnosis, mainly through the use of the malaria rapid diagnostic tests, as well as the malaria microscopy, ensuring that every suspected malaria case is tested before they are treated for malaria. And in terms of future efforts, we recommend that case management initiatives should prioritize lower level facilities, mainly the health center 3s, and we focus on improving referral between these centers to the higher levels, because most of malaria cases are actually seen at the lower level health facilities. We also would like to recommend that we institutionalize the aspects of quality improvement specific to severe management, and mainly in regard to clinical audits and mortality audits, so that we continue reducing malaria-related death. At community level, we'd like to recommend that ICCM is scaled up to cover the entire country, and targeting those communities are mainly in need, especially the hard-to-reach remote areas. Data use is very critical, and our learning has been that data is mainly used for reporting purposes at indicator level. But then we'd like to recommend that we focus more on improving the quality of data, and as well as the use of data to include, the analysis on the risks to malaria in terms of populations, behaviors, and then even behaviors not only at the human behavior, but as well as the vector mosquito behavior, so that we are able to develop integrated decision-making mechanisms. In terms of social behavior change initiatives, we need to strengthen interpersonal communication between the health providers as well as clients, so there is common understanding of the malaria risk across board. And it's critical that communities are mobilized to participate in malaria service delivery using relevant data that comes from those very target communities. And we need to continue investing in operational research, especially in efficacy studies, so that we are able to monitor the effectiveness of the malaria treatment medicines, and that the potential to detect resistance is timely. And then we should be able, in terms of capacity development, include the wider participation from the political stakeholders as well as the administrative aspects of the program, and not only the technical perspectives. Allow me acknowledge these people. I would like to greatly thank the Ministry of Health for the stewardship and the leadership and the support that they have provided over the period of implementation of this project. The districts, health facilities and communities that have been the lead in implementing the interventions, PMI, USAID for providing the funding support, and then Malaria Consortium for leading the implementation of the project in close collaboration with its partners, JAPAIGO, Banyani Global, Deloitte Uganda, CDFU, IDI, and IDRC. And we'd also like to acknowledge some professional associations, especially the Uganda Pediatric Association, as well as the Uganda Private Midwives Association, that worked with us very closely to implement interventions in the private sector. Last but not least, we'd like to acknowledge the role and the support and the encouragement of the Rollback Malaria Partnership in Uganda. Thank you all.